My name is Samar Al-Duri, and I'll be touching up a little bit on some of the things that we've covered so far today, which is Barretts Oesophagus surveillance guidelines and when to stop. The main learning objectives that we're going to be discussing today is to recognize the progression risks in Barretts Oesophagus. We'd like to understand the surveillance goals in these patients and to tailor the surveillance intervals and to identify criteria for safe discontinuation of surveillance, understand the role of endoscopic therapy, and finally, as we're approaching this era of personalized medicine, is to personalize and tailor how we should do this depending on different scores that are up and coming that maybe could be used in clinical practice. So why do we do the surveillance in Barretts Oesophagus? So the progression risks of Barretts Oesophagus is the only known precursor to esophageal adenocarcinoma. About 95% of cases are linked to Barretts Oesophagus, but many do not even have that diagnosis before they show up, which means there is a problem when it comes to screening. And of course, the progression risk always depends on the dysplasia grade. So it can vary from 0.3% annual risk of progression up to 20% annual risk of progression, depending whether they have non-dysplastic Barrett's or high-grade dysplasia. And so the goals are to detect dysplasia or early adenocarcinoma, where we can perform some sort of endoscopic therapy, reduce cancer-related mortality, and also this endoscopic perspective for us as gastroenterologists to identify that subgroup of patients that actually might benefit from our interventions. And we would like to first minimize the harm of these patients so that we don't overdiagnose or underdiagnose patients. We've talked about this a little bit today, where in many parts of the world there's not enough slots for upper GI endoscopy, and as well as if you give a patient the diagnosis of Barretts Oesophagus in some parts of the world, it will affect their insurance premiums. It will affect a lot of other things that something that they can never really get rid of. So, and the challenges here is like the pathologist variability. So we have low-grade dysplasia diagnosis shows high inter-observer disagreement, and the access to expert pathologists is not available in every hospital. So, and a little bit touch up a little bit on discontinuation criteria, so when to stop surveillance. I'll be mentioning different parts of the guidelines, which is like the ESGE guidelines, and a little bit from the ASGE guidelines and the AGA guidelines, where they more or less overlap in regard to most of the recommendations that are made nowadays in regard to surveillance and when to stop surveillance. Overall, so there's a recommendation to consider stopping surveillance if patients are above 75 years of age, if they're comorbid and have a life expectancy of 5 years or less. That's where the risk of endoscopy outweighs the benefits. The other reason that might be a possibility for for stopping surveillance is post-eradication stability. So if a patient has been successfully treated and on successive gastroscopies we have not seen any signs of recurrence, then it could be possible to stop surveillance. And there's also a scientific justification as to why we should do this. And I think as we are learning more and more about this condition, and with the advent of artificial intelligence and everything, we're going to be able to achieve even better surveillance when it comes to this.